Hello, this is Michael Savona, and I direct hematology research here at Vanderbilt-Ingram Cancer Center at Vanderbilt University Medical Center here in Nashville, Tennessee. Today I'll be talking about slowing the rate of progression of myelofibrosis. For many years, the standard therapy for myelofibrosis was palliative in nature, concentrated on lowering counts and reducing the size of the spleen. Recently, new therapy carries the promise, or at least the hope, of returning to normal hematopoiesis. As seen here, the Phase 3 ruxolitinib versus placebo COMFORT-1 trial had a secondary endpoint of reduction in total symptom score. Patients who were on the ruxolitinib arm had superior reduction in symptoms to the patients in placebo arm. The reduction in spleen size seen in COMFORT and the reduction of symptoms is thought to be cytokine-driven. We know that patients with myelofibrosis, regardless of whether they have JAK2 V617F mutation, have increased cytokine levels across the board. On this LumenX array, it is clear that patients with myelofibrosis have high levels of cytokines as indicated by red. After treatment with ruxolitinib, these samples show reduction in cytokines as indicated by green. Regardless of V617F mutation status, patients with myelofibrosis have inflammation which is improved with the JAK inhibitor, ruxolitinib. While reduction in fibrosis is certainly not seen in all patients, there is some early evidence that JAK inhibition with different JAK inhibitors can lead to reduction in fibrosis. The panel indicates how after just 6 cycles, there's a slight reduction in reticulin fibrosis, but after 30 cycles, there's resolution of fibrosis and what appears to be more normal hematopoiesis. Further, in attempts to allow patients with low platelets the opportunity to receive the benefits seen with JAK-STAT inhibition, a low platelet study was conducted with ruxolitinib, allowing patients to receive increasing doses with a careful titration of ruxolitinib. And while patients had a median platelet level of 67,000 at the beginning of the study, did not have a statistically significant drop in their platelets at week 24, it's worth noting that a small number of patients actually had a paradoxical increase in platelets. This is borne out in practice, where some patients who have drastic spleen reductions actually have platelet increases upon treatment with ruxolitinib, a drug with the known toxicity of thrombocytopenia. While it's unclear of the effect of ruxolitinib on the transformation to acute leukemia, and the improvement in hemoglobin and platelets has not been achieved universally, there is a survival benefit, and this is likely due to the reduction of inflammatory cytokines over time in myelofibrosis. The effect on clonal burden and clonal evolution remains an ongoing inquiry. While resolution of ineffective hematopoiesis and removal of the clone have not yet been established, symptoms have improved, spleen size is reduced, and survivals improve with JAK-STAT inhibition. Capitalizing on this strategy, new clinical trial opportunities involve combination study with ruxolitinib and a variety of different agents, including PI3 kinase delta inhibitors, DNA methyltransferase inhibitors. It's hopeful that these combinations maximize the benefit of ruxolitinib in patients with myelofibrosis, reduce the risks of transformation to acute leukemia, further improve survival. Thank you for listening.